Thank you for joining us for today's virtual symposium, A Pathway to Individualized Hemodynamic Management, incorporating pressure, flow, and predictive parameters. Understanding the root cause of hemodynamic instability in the ICU can be challenging. Incorporating minimally invasive monitoring can now help us understand on a deeper level a patient's pressure and flow dynamics and guide more individualized care. The Acumen technology was first introduced to the OR setting in 2018 to meet the increasing body of evidence that there are strong correlations between hypotension and comorbidities such as MI, AKI, and even death. If you happen to be familiar with the FlowTrack sensor, which provides continuous arterial-based cardiac output and stroke volume, the Acumen sensor is similar in the fact that it's an arterial transducer that provides all of the data currently offered on a FlowTrack, as well as additional parameters such as the Hypotension Prediction Index, or HPI, Eadyn, and dP by dt. So over the past year, we've seen a lot of interest in using this technology in the ICU setting. So while we still have a lot to learn, our three speakers are going to review their experience using the technology in a variety of settings. Dr. Simon Davies will begin the presentation by introducing the technology. Dr. Davies is a consultant anesthetist at York Teaching Hospital NHS Foundation in the UK, and was one of the first physicians in the world to incorporate Acumen into his practice. Following Dr. Davies will be Dr. Brad Cardinal from the University of Missouri. Dr. Cardinal currently serves as the Director of Cardiovascular Anesthesiology, as well as an Assistant Professor of Clinical Anesthesiology, and will share his unique experience using HPI and the additional parameters in the cardiac OR and cardiac ICU setting. Our third speaker today is Dr. Mike Scott from the University of Pennsylvania. Dr. Scott is the Division Chief for Surgical and Neuroscience Critical Care and also serves as a Professor of Anesthesiology and Critical Care. In addition to previously using the Acumen technology in the cardiac OR at VCU, Dr. Scott has also recently had the opportunity to see it in action in the ICU setting at UPenn. So as we're listening to the following presenters, I'd like to encourage everyone to submit your questions via the Q&A function within Zoom. And we should have about, I think, about 20 minutes at the end for open discussion. So with that, Dr. Davies, if you'd like to go ahead and share your screen, you can go ahead and kick us off.
Lovely, thanks, Nora. Let me just share my screen and we will get underway. Wonderful. So I'm going to talk a little bit about perioperative hypertension and some advances in the treatment or in understanding the underlying physiological cause of hypertension. And really that is to set the ground for my two esteemed colleagues, so Brad and Mike, to show how they manage treating hypertension and flow effectively in day-to-day clinical practice. My disclaimer is I'm a paid consultant for Edwards Life Sciences. I'm also not an intensivist, but I have a strong interest in perioperative medicine. And we run level 2 patients on the ward now in our establishments, managing flow and pressure in the post-operative setting. So either way we look at it, hypertension is a problem in our day-to-day perioperative practice. It's problematic in that we've defined rather nebulous numbers as thresholds of hypertension. We still remain uncertain as the true optimal threshold, which is unlikely to be one number for all. Problematic in that it's so easily treated, we may well end up causing harm if we don't stop and think about what we're doing when we are actually treating it. What is clear, though, is that pretty reasonable definitions of hypertension, it is certainly prevalent in the perioperative population. Thresholds of, say, 65 millimeters of mercury, then up to a third of patients are exposed to harm at this level in terms of kidney and cardiac injury, and also possibly mortality as well. It has now become an entirely preventable entity. If you can predict hypertension, and there are machine learning algorithms such as the Hypotension Prediction Index that do that, that predict hypertension up to 15 minutes before it occurs, then we can realistically significantly reduce the burden of hypertension in our patient population. It's also harmful, and the caveat here is most of the evidence is observational. It's association, not causality, but there's over 500,000 patients in the observational work, and a very consistent message that lower and longer in terms of hypertension is worse for patient outcomes. Now, there are some limited prospective work from Emmanuel Foutier's group that showed that managing hypertension reduces complications, but can we actually just do nothing? No, we can't. But with caution, as a cure, if incorrectly chosen, may be just as bad as the burden of disease. What's currently true at the moment is the cumulative duration of hypertension really matters, not single episodes per se, and we seem to have settled initially at a threshold of around about 65 millimeters of mercury. But things continue to move on. More recent work sets the bar higher. This is from ANA, published recently. Almost 500,000 non-cardiac patients undergoing surgery, and harm or a signal to harm was shown here at thresholds of 75 millimeters of mercury. But interestingly, the harm seems to be multifactorial, so cardiac, kidney, cerebral, and inflammatory outcomes, as well as mortality. But because of the potentially avoidable nature of this hazard and the extent of the exposed population, it makes hypertension in the operating room and beyond a serious public health issue that cannot be ignored for any age group. And because of this, we see CMS introducing MIPS for hypertension, and there's guidance starting to come out from entities such as POCI suggesting we should be managing hypertension more effectively. But also, let's not forget about post-operative hypertension. It's just as important. Surgery is not just an intraoperative event, it's a continuum through to recovery. The physiological insult lasts for days, so it's naive to think that just managing it in the intraoperative setting is enough. It needs to be managed until the patient is fully recovered from surgery. This is data from one of the POISE trials. The odds ratio for MI or death was almost 3 for those experiencing post-operative hypertension on days 1 to 4. However, hypertension in the post-op period occurred mainly in those that had intraoperative hypertension. So perhaps it's just a continuation of the same process, and the higher odds ratio represents the higher time-weighted average of hypertension accrued by this group. It's unlikely, but possible. But new evidence suggests that patients admitted post-operatively to the ICU who had no identified instance of hypotension in the intraoperative period, that new onset hypertension in the post-op period was associated with similar adverse outcomes and a similar pattern. The lower the blood pressure, the longer it's low for, the more harm there is. So hypertension and its burden is not isolated to the intraoperative period. Good hemodynamic management is essential in the post-op period to avoid poor patient outcomes. Most of the studies we looked at so far are elective non-cardiac surgery, but what about the ICU population? Here it starts to get a wee bit difficult. In elective patients who need critical care, it's not unreasonable to assume the same rules apply. But what about those with established illness? It all gets a bit muddy here, to be honest. We have information from large data sets that shows the risk of AKI and MINS and mortality is associated with mean pressures from anything from 55 to 85. Again, these are retrospective and observational. We have results from an individual patient meta-analysis of 2 prospective trials evaluating MAP targets, so sepsis-PAN, and the OVATION trial. And they suggest that higher exposure to vasopressor to obtain higher MAPs leads to an increased mortality in the older patient group and also higher renal replacement therapy. But the more recent results are from the 65 trial, 2,500 patients randomized to normal care or permissive hypertension defined as a MAP of 60 to 65 with a view to reducing exposure to vasopressors. Permissive hypertension group had a lower exposure to vasopressors, but no difference in the outcome, which was 90-day mortality. So with those with established vasodilatory hypertension or potentially a different group in whom the target of 65 or higher may not be beneficial, it remains uncertain at the moment. What is clear, though, is there's a very large variation in practice. In the usual care group, greater than 20% had a MAP of greater than 75 with no dose adjustment to vasopressors. And again, 20% of the group had a MAP of less than 65. There was also a hint of benefit to being allowed to be permissively hypotensive in patients who are chronically hypertensive, so rather counterintuitive. A secondary analysis is not powered for this, but an interesting observation, and there may well be reasons that permissive hypotension, or rather reduced exposure to vasopressors, may offer benefit. So in the ICU and theatre, hypotension could be abolished by just running a vasopressor infusion, but is this the right thing to do? The above here is a porcine model. On the face of it, it all looks quite stable. So we've got a good blood pressure, adequate stroke volume, adequate cardiac index. SVV is relatively normal. However, this is a 70-kilo animal that has been hemorrhaged 1,000 mils of blood, and hemodynamics have been normalized by the use of vasopressor infusion. Does this matter? It does, because we're robbing Peter to pay Paul. If you're hypovolemic, we are simply altering the ratio of stressed and unstressed volumes to maintain central euvolemia whilst we are globally volume deplete. On the left of the screen there, we can see a picture of our intestinal microcirculation in the small bowel at the level of the villi using side stream dark field microscopy. Normal constant flow, all areas perfused. But on the right-hand side, it's the same circulation after that 1,000 mil of hemorrhage. Remember, macrohemodynamics are normal. They've been normalized with a vasopressor, and this is a gut with no flow, one that's in trouble. It's not about aiming for a nebulous number in terms of blood pressure. It's balancing our circulation to achieve optimal flow and pressure with the correct therapy. And Professor Scott and Dr. Cardinal will show this shortly. We can maintain macrohemodynamics with a vasopressor through all stages of hemorrhage. This is a hemorrhage from 5 up to 20%, all normalized in terms of mean arterial pressure with a vasopressor infusion. Our stroke volume, pulmonary artery pressure, cardiac output, whatever you measure, remains completely normal due to the vasopressor infusion and the shifting of blood from unstressed to stressed volumes. And whilst we can make all the numbers look great, beneath the bonnet, all is not well. These are microcirculation scores through the different stages of hemorrhage. And we resuscitate the model with around about 10 mils per kilo. And then if we apply a vasoconstrictor, we see no difference in our microcirculation score. If you squeeze a full system, there is no deleterious effect on the intestinal system. But even small volumes or small volume loss dramatically affects microcirculation score. And if we apply a vasoconstrictor at this point, we actually worsen things. We're just changing numbers on the screen on our macrohemodynamics to make us feel better. Beneath the bonnet, the microcirculation is struggling. We see this again at 10% hemorrhage, again with a vasoconstrictor, but importantly, this can be reversed. It can be resuscitated. Now, the 1,000 mil loss was an extreme example, but this slide on the right, or the video on the right now, is showing a 5% hemorrhage, around about 300 mils. And just ventilating somebody with positive pressure roughly does that. So a small amount of volume deficit. And it doesn't always come across very well on Zoom, but what we see here is pulsatile stasis in certain areas. We have to be able to understand the underlying physiology that is causing hypotension and treat that accordingly, not just the mean arterial pressure per se. And to do that, we can use some of the advanced hemodynamic parameters to help us determine what the underlying cause of the instability is and what the appropriate treatment may be. Both flow and adequate pressure have to be maintained in tandem, and we don't necessarily measure the right things to allow us to do that. We cannot manage blood pressure with a CVP and an arterial line alone, and nor should we, because it's balancing both flow and pressure. It is not about pressure alone, that nebulous number. It's about individualizing our management to obtain optimal hemodynamic stability. Advanced monitoring gives us some more information or guidance beyond pressure waveform, but this in itself may not be enough in its current format. So we have to turn to imaging techniques such as echo, but these tend to be intermittent and not continuous measurements, which have some limitations due to this. But we can use these techniques such as echo to calibrate surrogate measures, for example, of contractility, that we can then measure continuously from a baseline predetermined by ourselves. Management of our optimal perfusion and flow often demands a combination of both fluids, inotropes, vasopressors, and other adjuncts to achieve the desired endpoints. But we don't monitor the effects of these treatments on a continuous basis, and nor do we often have information to help us if our intervention will work a priori. Contractility is one of these things we don't measure particularly well, and it's underutilized in the operating room and also in the ICU, except at intermittent moments with echo at bedside. Now, physiologically, contractility is the slope of our end systolic pressure volume relationship. And the gradient of this is our end systolic elastance, and that is a measure of our myocardial contractility. The steeper it is, the more contractile the heart, the flatter, the less contractile. But we can't measure this particularly easily. And so we look to surrogates or alternative measures of contractility, one of which is the maximal pressure in change over time from a peripheral arterial waveform, also known as dp/dt max. And it's a surrogate for our left ventricular contractility. Now, it's a large assumption that end systolic elastance equals our left ventricular pressure time change equals this radial pressure time change. And they are not the same measurements. One underestimates the other, but they correlate with each other. And it provides us with a continuous measurement of change in contractility, which we can calibrate against echo measurements. So we use echo to get where we want to be, to get everything balanced, and use this continuum measurement to manage our patients in real time. Now, there are no normal values for dp/dt max. We have to decide what is optimal for the patient and then use this as a trending parameter. But the changes we see in dp/dt max measured from a peripheral artery correlate with what we see on echo. So this is a short axis view of the left ventricle, as well as a bit of mitral valve there from the lateral base of the right ventricular outflow tract using intracardiac echo. On the right-hand side, that grey arrow is where we give a bolus of esmolol in the porcine models. We can see our dp/dt decreases from around about the mid-300s, it's the bottom trend line there, to approximately half of its previous value. And this is related in what we see in echocardiographic measurements. We see reduced fractional shortening, larger end systolic volumes, and reduced stroke volume, or rather ejection fraction. So the changes in dp/dt, so ignore the absolute measurements, the absolute values, correlate to what we see clinically on echo. Does that matter? Yes, it does to a degree. This is a patient coming down to ICU who has some ventilator dysynchrony and receives a bolus of propofol. We can see our mean arterial pressure dropping there from around about 100 down towards the 50s. If we look at his hemodynamics, stroke volume is decreasing. We're not particularly fluid responsive. Our stroke volume variation is just touching to 11–12%. So what do we do? Well, the natural thing is to turn up the vasopressor or to give some fluid, but that is not the root cause. The root cause is a decrease in contractility in dp/dt. And if we start vasopressors in this situation, we'll end up squeezing a myocardium that has decreased contractility. And that's what we did do is give a bolus of ephedrine, and we see our contractility and our blood pressure resolve. But it's not only changes in contractility we don't use effectively to treat hypotension. We often perform interventions without knowing if they have the desired effect a priori. We don't measure the correct parameters. Let's think about a patient who's hypotensive. They're in a preload dependent state. We know that from SVV. We give them some fluid. We increase the stroke volume. But what will that do to blood pressure? We don't know. Because whether that blood pressure translates into an increase in pressure depends on a secondary parameter called elastance. Now, elastance is just the reciprocal of compliance. An effective arterial elastance has been proposed as a measure of our left ventricular afterload. If you draw a line through your end diastolic and end systolic points from PV loop of the ventricle, that is the line, and the gradient is our effective arterial elastance. Now, why is that useful? Well, when the aortic valve opens, the left ventricle sees the aorta. They become coupled. And it sees three pressures. It sees inertial mass, so the blood that needs to be moved. It sees the pressurization, so our end systolic pressure, and it also sees this elastic wall. I guess it's elastance. Now, when the aortic valve opens and these two become coupled, it's good to know if the aortic afterload is relatively stiff, so it has a high elastance, or relatively compliant, has a low elastance. Because in the first case, an increase in stroke volume will generate pressure. In the second case, that extra stroke volume will be mostly absorbed by the low elastic state of the large vessels. Now, this we can't really measure very easily. So there's the concept of what's called dynamic arterial elastance, or Eadyn, which has been suggested as a functional measure of arterial load. And it's the ratio of our pulse pressure variation to our stroke volume variation. It's a complex parameter. It's not a measure of arterial load per se, but just defines the dynamic interaction of changes in pulse pressure and stroke volume over a respiratory cycle. It is not the same as arterial elastance. It's not the same as SVR. A high Eadyn does not mean a high SVR or vice versa. But why is this useful? Well, firstly, Eadyn allows us to determine if in a preload responsive individual, then if we increase stroke volume, will that lead to an increase in pressure? Let's take a volume change. That's all SVV is. And at this point, we're on the low elastance, highly compliant part of a pressure volume curve. If that volume change does not generate pressure, then the ratio of PPV to SVV is low, so Eadyn is low. So when Eadyn is low, giving fluid to this individual will increase the stroke volume, the preload responsive, but that will not translate into an increase on pressure. Conversely, on the highly elastic part of the curve, the same volume change this time generates a pressure change. And so the ratio PPV to SVV is now high, so Eadyn is high. And so in this individual, if we give them fluid, the preload responsive, they will increase their stroke volume, and that increase in stroke volume will generate an increase in pressure. So Eadyn tells us a priori in preload responsive individuals who will increase their blood pressure to a fluid bolus. Secondly, it also tells us whether we can safely wean vasopressors without a drop in our mean arterial pressure. So this is work from Guino's group looking at vasopressor infusions in intensive care. If your MAT Eadyn was less than 0.94, then that predicted a drop in your mean arterial pressure if you decreased your vasopressor compared to those who had a higher Eadyn. He went on then to use this in a protocolized fashion. I think Brad will talk about this a bit more to on intensive care patients and reduce vasopressor exposure and also length of stay. Now, why does Eadyn predict a pressure response to fluid and also map stability when vasopressors are reduced? I'll bring some data. I'll explain why in just a moment. This again is from porcine models, and what we can see from these in various states of loading and unloading is that stroke volume variation is mostly affected by contractility, so end systolic elastance. And pulse pressure variation is mostly affected by our effective arterial elastance or large vessel afterload. Now, there is something called ventricular arterial coupling, which is a ratio of our contractility, ratio of our afterload EA to our contractility and systolic elastance. And the normal value is around about 1. And as we deviate from this from 1, we become less efficient or less balanced. Because when the elastances of the ventricle and of the large vessels are matched, there is greatest cardiac efficiency and the optimal transfer of blood from the LV to the aorta. So what we do is provide adequate stroke volume at the lowest possible energetics. Now, EA, we have said, excuse me, is mostly affected by pulse pressure variation, whereas contractility mostly affects stroke volume variation. And therefore, actually, Eadyn is a measure of our ventricular arterial coupling, and this explains the clinical benefits that we see. In terms of being a pressure responders, those with a high Eadyn have a ventricular arterial coupling much closer to 1. So they are energetically, they are very efficient, so they're very balanced, and therefore they can move from being energetically efficient to being more mechanically efficient. Essentially, they can increase their stroke work, and that increase in stroke volume generates pressure. And the same for vasopressor weaning. Those with the lower Eadyn are further away from this balanced ventricular arterial coupling. And so when we reduce vasopressor, they can't increase their stroke volume or stroke work rather to compensate for the decrease in afterload compared to those that had the higher Eadyn who could increase their stroke work and maintain blood pressure. So hopefully that sets the scene for some of my colleagues. And really my message is that hypotension is frequent and it is associated with harm. The current evidence suggests that MAP should be greater than 65. This may change though, but only upwards. And it's not just about intraoperative MAP, it's about our post-operative management of mean arterial pressure as well. Just running a vasopressor is not the solution to treating pressure, and we need an individualized strategy based on the underlying physiology, and that requires more advanced monitoring. So I'll stop there and hand over to Brad next. Now, as Nora mentioned, Brad is Director of Cardiovascular Anesthesia and also Assistant Professor of Clinical Anesthesiology based at the University of Missouri. And Brad's got a huge amount of experience using HPI in advanced parameters, and I'm really excited to hear what he has to say. Over to you, Brad.
Perfect. Thank you, Simon. Hopefully everyone can hear me. Yeah, I'm going to go over a couple examples and just our experience here at the University of Missouri to kind of show the practical portion of how this can be used. As Simon mentioned, I'm a paid consultant of Edward Life Sciences as well. And I'm not an intensivist either, but I've had to have experience in helping implement some standardization of Acumen IQ in the ICU, and I'll go over that. So what I want to think about is that pressure versus flow that Simon talked about. I think in medical school, and in residency, we all know that we were taught about perfusion, and that's the important part, where we get that flow and oxygen delivery to the tissues. But there wasn't really a great way to practically bring that into the OR or to the ICU bedside setting, and to be able to adjust that balance of pressure versus flow. I think we just had to assume that if there was adequate pressure, if there was adequate hemoglobin or oxygen saturation was okay, then our tissue perfusion had to be okay. Until we reached that certain point where we see clinically, we were on high dose vasopressors and we were monitoring by serial ABGs or lactates, maybe even a mixed venous or central venous. And then we saw that, with those numbers worsening, then we were on higher dose vasopressors, which was causing more harm. So as I go through this, I want you to think about that picture of this gut microcirculation. And think about the patient at your bedside and how to balance that pressure versus flow. I think in my experience in the OR, and most anesthesia, maybe not most, but a lot of anesthesia providers have their set way of how they treat hypotension, and some of it is a little lax, as we've seen from some data. And I think a lot of people use either fluid or phenylephrine, and maybe you've received some of these patients from the OR and seen the same thing. And I think this correlates to the ICUs as well. I think each ICU kind of has their preference or bias in how they treat hypotension and perfusion. And maybe it's start with volume, then go to a pressor, and maybe rarely you get to inotropes, or maybe it's always a third option. And I think we need to think about that balance to be able to treat these patients with the proper techniques to give them the best circulation. So as a cardiac anesthesiologist, I have the advantage of having a TE in all my cases. And I just kind of want to show this example to show you what the TE looks like and what we see on Acumen IQ or hemisphere monitors here. So on the top, we see on all of my cardiac surgery patients, we monitor 3-block symmetry. And again, at University of Missouri, we have Acumen IQ in all our cardiac surgery patients now as well. So we see the cardiac index here and our DPDT here. On the bottom, we have our stroke volume, a CVP, our SVR, and our hypotensive predictive index, or HPI. So as you can see in this mid-esophageal short axis view, what we're mainly looking at is, our HPI is high, so we're at least hypotensive or have a high likelihood of becoming hypotensive. And then we're going to look at our secondary parameters to see how we're going to treat that. We see our DPDT is a little bit lower than what our baseline was. And we also see our stroke volume is lower than what our baseline was. And I know that's hard to see from these images, but we do an intervention, which includes fluid bolus. And then we look at our DPDT and how we corrected that, as well as our echo. And we can see that the heart is a lot happier here. We have a lot more contractility that's judged by both the echo as well as the same thing we see on DPDT here. We saw our stroke volume went from 53 up to 74. Our CVP did go up a little bit, but this is not a great judgment of our volume status, but we continue to monitor this for concern for right heart failure in these cardiac surgery patients. And we can see that our SVR really didn't change that much. So again, this is kind of just one of those examples to show you that what we see on the hemisphere monitor or Acumen software is similar to what we're seeing in the heart. And we can also correlate these echo images to our Acumen IQ. So in the cardiac OR, we get to see the heart and how it behaves. And then we see what these numbers mean on the Acumen software. And then we can take that data and inform the ICU that this is how this individualized medicine or this patient behaves with a certain DPDT or SVR, or pick your parameter to kind of individualize that approach to these patients. This is another example of how I used HPI and DPDT in a patient for a CABG with a mitral valve replacement. This is after induction and prior to bypass, and kind of like the screen before, I have similar parameters, although I changed some of these around in the OR depending on how the patient behaves. On the top, we have our HPI. Here's our mean arterial pressure, our cardiac index, and our DPDT. Again, we have cerebral oximetry in all of our patients. And then on the bottom, we have SVR, Eadyn, our stroke volume, and our stroke volume variation. So what we can see, and again, this is six times speed just to get through it, but we can see our HPI is going up here, which means that our patient has a high likelihood of becoming hypotensive. We're still not hypotensive if we're going to judge that by a MAP of 65. So if you're just looking at your gross parameters, you may not treat this. But what we can see is our DPDT is dropping off pretty significantly here. And so as you can see, that was treated with the epinephrine bolus or inotrope, which increases our DPDT. Our cardiac index is a decent judge as well, but as you can see, our cardiac index is never really coming into the red, and it drops a little bit, but not significantly, not as much as you can see by the DPDT. And once we know that this patient is behaving like this, and we've given a bolus about inotrope, we can then transition them to a drip, obviously, to have a more smooth hemodynamics. But the whole goal is that we never let the patient become hypotensive here. We got them to a MAP of 64 or so, but if you're just looking at your gross parameters and just looking at the regular arterial line, you wouldn't necessarily treat that patient until they got below your MAP goal. And so this is an example of how we used HPI and DPDT. So one of the surprising things for me, which I was able to learn with Acumen Analytics, or the analytics software that you can use with the Acumen IQ, is the amount of hypotension that actually occurs. And this shows just one case example of a patient that I did a CABG on, and it shows the amount of hypotension in the OR, and then also followed this patient into the ICU. And I think this just shows the huge opportunity for improvement that we have in our patients and how important the ICU care is. And it doesn't matter how well I take care of the patient in the OR or how well our colleagues do when we have all the tools available, such as an anesthesiologist with less than 2 or 4 patients, a constant anesthesia provider looking at the hemodynamics. There's a lot of resources in the OR that the ICU doesn't have the advantage of. But I think that we do have the opportunity to provide some of those resources to the ICU, such as these secondary parameters that are available on the Acumen IQ. And so what I want to show is that we've been able to take that individualized medicine or individualized approach to these patients and show the ICU and provide that information to the ICU. And again, it doesn't matter how well we take care of the patients in the OR. If they're hypotensive 33 or 31% of the time in the ICU, then the patient's still going to have the same risk for the comorbidities that come with that. And this isn't just post-operative patients either. So these are patients from the MIMIC database out of Boston. And these are patients with distributive shock. And they had distributive shock for at least 6 hours of vasopressor use. And then the goal was to look at the percent of time that they were hypotensive. And so if we're judging, again, as Simon talked about, we don't necessarily know what the MAP goal is or best practice is. But if we judge it by a MAP of 65, 60, or even 55, we're not really meeting those goals either. So this data here shows that 62% of the patients had a MAP less than 65 for at least 2 hours, and 37% of the time they were below 60, and then 18% of the time these patients were 18% of the patients were below a MAP of 55. And of course, these had downstream effects. So the mortality went up by around 5%, 8%, or even 15% when they were below these MAP goals. And again, this is just a different ICU population to show that there's opportunity for improvement. So if there's opportunity for improvement, how do we get that to the bedside to a practical standpoint? And what this is our decision tree we used at University of Missouri and all of our post-op cardiac surgery patients to help standardize the approach. Right now, and before we started using this, I would ask, how did we titrate the vasopressors overnight? And a lot of the time I would get the answer of clinical experience, which is the ICU nurses have a tremendous amount of clinical experience that is very helpful at the bedside. But there are also new ICU nurses that don't have that clinical experience. And I don't think it's fair to those patients that they don't get the same amount of care or the same clinical experience. So I think as we move forward in medicine, we need to get to more standardized approaches to give the patients the best chance for decreased comorbidities. So in the cardiac, we use our MAP goal of around 65, although this can be changed if there's certain pathophysiology that the patient behaves at or needs. And then the first thing we're going to do is look at volume status. So we can judge this by a stroke volume variation of greater than 13%, or if we're not able to meet all the parameters necessary for stroke volume variation, we can look at delta stroke volume of greater than 10%. So the nurses have the option of giving a 250 ml bolus and looking at the delta stroke volume. And if the patient's fluid responsive, then they're going to provide more fluid. And they can do this up to 3 times. So the other advantage of this is the patient's not going to get volume overloaded, because they're judging if the patient is volume responsive and not just giving volume because they think that may be what the patient needs. Next thing we're going to look at is our SVR. So here we've changed this and modified this recently to have this blank, because again, we can see how the patient behaves in the OR. And this is one of those opportunities that we've seen that is pretty variable per patient. Some patients, if we get the SVR to 1200, their cardiac index goes up without any inotropes. And some patients only need an SVR of 800 on the monitor. So this is where we're going to tell the bedside nurse as well as the ICU team, this patient needs an SVR of 1100 or whatever that number is. And you can keep going down the algorithm, and we get to DPDT over here, and we have 400 here as just a baseline. But again, we change these numbers as well based on how the patient behaves. And this isn't meant to take away the clinician experience or expertise. It's just meant, since the clinician or the physician is not able to be at the bedside 24 hours a day, it gives some objective data for the bedside nurse to be able to titrate these drugs. And of course, if the patient doesn't behave like textbook, down one of these lines, 1 through 5, they get to a place where they go ahead and seek expert consultation and talk to the physician or the clinician in charge of helping take care of the patient. So the next thing is, as we mentioned, was Eadyn and the titration of vasopressors. So this is an algorithm with a hospital based out of Nashville or in Tennessee, and they're using an Eadyn to help titrate those vasopressors, as this 2017 France study showed they were able to do that. So we start here with the Eadyn greater than 1, and if the Eadyn is greater than 1 and the MAP is above goal, go ahead and decrease the vasopressor, see what the response is. If the MAP decreases, then you have 1 of 2 options. You can go to, if the patient's preload responsive, then you go ahead and give the volume. If they're not, then you increase the vasopressor back to achieve the MAP goal. And the way I kind of think about this is maybe the success that we had with the Foley catheter use. So initially, when a lot of us were in training, the Foley catheter wasn't removed unless the physician or the clinician gave an order to remove the Foley catheter. And then we've seen the transition to nurse-driven protocols to help get these patients mobilized, get Foley catheters out, get lines out. And I think we need to take the next step to titration of vasopressors, and with objective data, such as Eadyn and our secondary parameters. So hopefully we can decrease the amount of vasopressor use, decrease the time. And as we saw in this study here, it decreased the ICU length of stay as well as the hospital stay. So just think of this, these kind of pictures when you're taking care of your patients at your bedside. Never forget perfusion. As we've seen from the data that Simon went over, and we'll see from additional experiences that Dr. Michael Scott goes over, is it's not necessarily a MAP goal we need to get at, but we need to think about how to actually get that perfusion and the oxygen delivery to the tissues that we need to. So on the left, this is a patient that's relatively healthy in early sepsis. The patient is on the right, this is late sepsis. Both have the exact same or similar blood pressures, which are both adequate blood pressures, but I don't think we're accomplishing the same goal with both of these patients. So with that, I'd like to turn it over to Professor Michael Scott to go over some additional examples that he has taken care of these critically ill patients in the ICU.
Thanks, Brad. Just going to bring my screen up. So I'd like to now demonstrate how I've used the Acumen Hypotension Index software in 2 out of the last 4 weeks clinically on ICU, both in surgical and medical COVID patients. So this is real life. And I think what it will do is demonstrate the wide clinical application and how it can support your decision making and also the bedside nurse. Disclaimer is obviously I'm a paid consultant of Edwards Life Sciences. But I'd like to illustrate clinical utility and this term that we've been using where I last was in Virginia Commonwealth University of a balanced circulation where you optimize filling of the heart, cardiac output and flow, and then maintain pressure. I'd like to show how we can use this software to assess preload responsiveness and optimize preload, how to empower your bedside nurse and give them targets to titrate both volume and vasopressors, and also show how you can use it in difficult COVID patients with ARDS and right ventricular dysfunction, which a lot of people have always thought you couldn't use this type of software on. So I talk about balancing the circulation, and really all it is ensuring that you've got enough filling and venous capacitance, because Simon's shown very well that you can actually stress your blood volume and create normal parameters, but you are robbing Peter to pay Paul, and it's the gut that suffers. Measuring flow is important because it's easy to measure pressure, but it's hard to measure flow. But obviously with this device, we have a flow indicator. And then after you've effectively done this and set your preload and flow, it's just a question of titrating your mean arterial pressure for adequate perfusion of your organs. And I do this really with, I try and ensure that people always look at the clinical picture. Bedside echocardiography, I think, has a huge amount to add. And the problem being is it's a one-off. And so the advantage of using this with the Acumen IQ sensor is you can set your patient in the middle of the road, get the circulation balanced, know everything is where you want it, and then use the sensor to basically keep the patient's parameters normal. It is important, though, always to look at the peripheral perfusion. And then the other advantage of this is the fact you've got the hypotension prediction index, where this detects the likelihood of hypotension defined as a mean arterial pressure of less than 65 millimeters of mercury for greater than 1 minute. And this gives a 15-minute heads up to your nurse that the circulation is effectively becoming unbalanced. So this is how I start my bedside assessment. I basically use TTE and normally a subcostal view, and look at the IVC, both the diameter and collapsibility. And I know everyone keeps talking about the fact you can't predict fluid responsiveness from the IVC, and you're absolutely right. But what you can do is use this as a central blood volume indicator. So I really like to know whether there's high, low, or a sort of normal venous capacitance. If you've got a high venous capacitance or high volume with very little phasic flow, but you also have to exclude wrong information. So I like to look at the right ventricle and tricuspid valves and make sure there's no backup. After I know that the venous capacitance is optimized and the fact that it's correct information, I then use whichever view I can obtain, because often the problem with echo is you can't always get good views in every position. So wherever you can, really, subcostal, parasternal, long or short axes or apical views to look at contractility and regional wall motion. The parasternal short axis is also very useful. And then after I look at that, and I might consider adding low dose inotropy just to effectively fix the revs of the engine is the way I sort of describe it. I look at the right ventricle, just check that there's good longitudinal shortening, it's not dilated, and ideally use a TAPSE measurement on a forapical chamber view to do this. Once you've really got the patient in a balanced position, you then want to really fine-tune looking at fluid responsiveness. And the great thing about this machine, you can see here with the images, is it leads you through this, and you can track both passive leg raise, a 250 ml fluid balance bolus, or a vasopressor or inotrope change. I think it's important to say that when I give a fluid bolus, I use a syringe and a three-way tap, because if you set your pump at 999 mils an hour, a 250 ml bolus takes 15 minutes to give, and that really isn't the way to see if you're truly fluid responsive. So the other thing you can do, looking to fine-tune preload, is we've got obviously a continual output of stroke volume. So you can look at the change in stroke volume, which is calculated from the arterial waveform and the area under it, as well as a few other parameters. Or you can use what are the well-validated parameters, stroke volume variability and pulse pressure variability. These are validated in patients who are ventilated at 8 mils per kilo ideal body weight. Now, I know people say, well, we're in the era of COVID and everyone's using low stretch 6 mils per kilo. What I do is I just go in and I adjust the ventilator to 8 mils per kilo and wait for about 5 minutes and see what the values are, and then go back to 6 mils per kilo. Another example of using the monitor, these are all real live examples that I've done in the last, the 2 last weeks of clinical practice. This is a patient who had COVID. We had the Acumen sensor pointing through the doors so that we could track the monitor. And then the patient was bleeding during the night, and the heart rate had remained fairly constant, and the MAP was above goal, and the MAP had drifted through the night because people thought it was sedation related, but my ICU fellow was very smart. She sort of looked at the monitor and she realized that the SVV was tracking up as well. And so they went in and they identified the patient was bleeding and actually treated the problem before the patient actually became hypotensive. Some people always ask me, in this example here, you can see P by dt also tracks down. And so people say, well, how do you know it's not a contractility issue? I think you always have to say that this is going to be a volume issue first, because P by dt obviously will track down if you're not optimally filled because of ventricular ejection. So it's bleeding or fluid loss first, and then if not, look at contractility. But it's normally only if you've got patients on inotropes that you would look for the dP by dt change. Here's another example, a surgical patient coming back post-op distal bypass with a known history of CAD. They also had a mild troponin leak on our first troponin study post-op. So we had the Acumen sensor up. We had adequate oxygen delivery by calculation with an HB of 8.4 and oxygen extraction with an SVO2 of 76%. But you can see here we had a very high afterload and a dP by dt which was high, so the heart was working hard. So in view of the troponin leak, I really wanted to reduce afterload and reduce left ventricular stroke work. So by seeing the SVV was low and the PPV was low, gave me the confidence to actually put some nicardipine up and titrate down the afterload pretty rapidly because I knew that the patient was inherently hemodynamically stable. The other great advantage of the way the hemisphere has been set up is you can set up and individualize your targets, and it's nice and simple. It's green for normal, yellow is out of range, and red is a natural alarm. And I found this really helped with the bedside nurses And this is an example here. You can see the stroke volumes just trending down from green to yellow, and the map's drifting down, but not at a level that you'd normally intervene. But obviously, as the stroke volume's coming down, we know that the gut is probably getting a little bit hypoperfused at this point. And the commonest intervention we normally do on ICU is allow a fluid bolus titrated to these parameters. So you can just then use this machine to target your fluid boluses just to keep people in the middle of the road and a nice balanced circulation. Another example here, we had a patient who came back from the OR. They had a poor LV function with an anterolateral hypokinesia. And they came back on epinephrine. Once the patient had sorted themselves out, you can see here that in the middle of this graph on the right, the P by dt went up, as did the map. And what this was showing is as the anesthesia was wearing off and the patients was tightening up their circulation, we were basically generating hypertension and increased left ventricular stroke work without actually any benefit in increased cardiac output. So it enabled us to titrate down the epinephrine, ensuring we had enough flow, but by minimizing myocardial work. So again, if you look at the risk of troponin leak in these patients is obviously high. So again, this was a good way of proactively reducing troponin leak in a patient with poor LV function. Brad's already talked about weaning from vasopressors, and I think this is very relevant because what we often do is we resuscitate the patient, and then you've got a patient in a steady state, and then you really want to wean slowly down off your norepinephrine. And what this machine can do is help guide your bedside provider. And so I think HPI is a useful indicator of how balanced your circulation is, and an Eadyn of greater than 1 with a low HPI normally means that you can start reducing your norepinephrine slowly. So finally, this is, I think, a picture that you're all very familiar with. This is just a few weeks ago here at the University of Pennsylvania Hospital. A severe ARDS patient on nitric oxide and lung protective strategy. They're vasoplegic. We've got the Acumen IQ sensor up, you can see on the left there, pointed towards the window with a secondary screen so that we could act off the numbers. So my approach to this was they had severe ARDS, COVID pneumonia and vasoplegic shock. So we knew the pulmonary resistance was high, and they're already on nitric oxide at 20 parts per million. A bedside echo, the IVC was full and phasic. It was a lady, and this is quite a high volume IVC. However, it wasn't obvious whether this was correct information because we did have a moderately dilated right ventricle with a low TAPC. And what was interesting is the LV was quite vigorous and obviously underfilled. At that point, she was on norepinephrine 18 mics, shot dose vasopressin, and we had a map of 62, a stroke volume 55, and an SVV, which was high. So all this suggested that we had an RV that was failing and a left ventricle which was underfilled. So basically, it completely reversed my norepi and introduced epinephrine. So we reduced the norepinephrine down from 18 to 4 mics and introduced epinephrine at 8 mics. And it was quite a dramatic bedside change. Our stroke volume increased dramatically, and the patient's blood pressure actually went up despite the fact that we'd reduced our norepinephrine. And I think this is a good example of balancing the circulation, even when you've got severe right ventricular dysfunction. You can see on the screen there, it follows this very nicely, and demonstrating this bedside to everyone, and really, I think, empowered our bedside providers to realize that you can really affect a change which has a meaningful result on the patient's physiology and a way of improving their outcome. So in summary, I hope I've shown you that the advanced parameters may provide additional guidance on how to optimize the circulation once you've basically balanced it using full flow pressure. Using echocardiography in addition to advanced parameters allows for improved information and interpretation. An individualized care strategy based on the underlying physiology can therefore be delivered. And the good thing about this is the additional data may help in measuring either a positive or a negative response to therapy. And then once the circulation has been balanced, the continuous parameters allow you to move away from the bedside and allow your nurses and bedside providers to maintain goals with either fluid boluses or titration of vasopressors or inotropes. So thank you for listening. I think what we're now going to do is take some questions in the chat. So please do post your questions in the chat there, and I will stop sharing my screen.
Thank you all for your excellent presentations. I think that was a great introduction to talking about the Acumen technology in the ICU setting and exploring the concepts of hypotension and individualized care through hemodynamic management. So I'd like to just go ahead and open up the webinar also if anyone has any questions you'd like to submit. But I'd like to start off by asking the three of you guys, what are your thoughts on kind of a standardized approach to high-risk patients coming out of the OR using hemodynamics in the ICU? Do you think that would make sense or difficult to accomplish? Dr. Cardinal, oh, yeah.
I'll go first.
Go first, yeah.
It's not difficult to achieve, and it is essential, I think. You know, we put all these resources and all this time into the intraoperative management of setting these patients up just right for, you know, an uneventful post-operative recovery, but then we don't provide them with much of a way of support. I think we have to realize is that we don't provide the majority of care for patients. Nursing staff provide the majority of care for patients. And so through the use of protocolized care, we can reduce variability in practice, and we can empower them to deliver the correct treatments to the patients. And you know, we've done this in York. We have post-operative protocols run by the nurses on the wards to wean the vasopressors, to give fluids, etc., etc. It's all very doable. It's all very deliverable, and actually the nursing staff really enjoy it because it gives them the skills to be able to treat those patients properly. I think, Mike, you were talking in Australia now. That's becoming a standard of post-operative care, is it?
Yeah, that's right. They're introducing it there after the success of basically post-operative 12-hour optimization, just basically fill flow pressure, getting it right. And you've demonstrated nicely how basically we're using all this technology in the OR, and yet a lot of our hypotension perioperatively is in the post-operative era. So, you know, the 12 to 24 hours after. So it's something we need to change the whole delivery of our perioperative care, don't we? And I think one of the biggest barriers is the fact that critical care is deemed expensive. It is expensive. We need to look at how we change nursing ratios in the post-operative period so that we can deliver this in a more cost-effective manner.
Yeah, and I completely agree. I think one of the advantages we had when we rolled this out as a standardization, we kind of we involved the nurses from the very beginning and let them kind of choose the algorithm that they understood best and that they think they could use. There's a bunch of different algorithms out there. You can kind of create it however you want, but the whole goal is just to standardize it across the board. And then you'll be able to adjust it once you know where the opportunities for improvement. But we involved them from the very beginning, kind of showed them the algorithms that were out there, and then we customized it to what they wanted so that they could understand it and use it on a daily basis.
Perfect. I know we're coming to the top of the hour. I do have one more question for you guys, and then we have one in the chat. But just curious on each of your inputs on whether some of these goals might be able to be achieved by, you know, trending your blood pressure, or whether you think it's really advantageous to add these additional parameters.
Well, I think I said in my talk, you need flow. But the great thing is Eadyn is giving us this new idea of of coupling which could be used. I think the other key thing is certainly some surgeons see an arterial line as invasive. So if we can move this technology to a non-invasive form, I think that will be the revolution that will enable this to be basically delivered for all patients in the post-operative space.
Dr.
I
Cardinal?
think we've moved on from pressure waveforms. I keep jumping in, sorry, terrible at Zoom. We've moved away from the era of just looking at pressure waveforms. We've known for decades now that optimizing flow improves patient outcomes. And this is about taking lots of different pieces of information. It's not saying that one is better than another. It's not saying you use this rather than echo or rather than X, Y, Z. You take all the information we can get, we sort of calibrate the patient to the monitor, and then we treat them in real time. And personally, I think, you know, you have to have measures of flow, you have to have measures of pressure, and these additional parameters now add in means where we can, you know, see the effects of our therapy and titrate them up and down accordingly.
Yeah, I think it's a balance. I think we tried to study pressure alone, and we can't find an absolute pressure number because it's not just about pressure, and it's about the balance. And I think that's where we'll get improvement in outcomes, is when we can find out how to balance that.
Excellent. Thank you all. I know we're just a little bit over time, and I think the introductory session is kicking off here. Just to respond to our question in the chat, about upgrading the FlowTrack monitor, I'd encourage you to reach out within our booth, and we can chat about different options. But it is essentially a separate sensor than the FlowTrack, and then it's just kind of a software upgrade for your monitor. So thanks all for joining us this morning. Please check out the Edwards Life Sciences booth for additional hemodynamic monitoring solutions and additional educational resources. This recording or this webinar is being recorded, so we look forward to continuing the conversation and chatting with you soon. Thank you all for your time.
Thank you.
Thanks very much.